So I want to welcome everyone to the call tonight. My name is Christina Bailey. I am the Director of Sales at Endologics, and I'm hosting the Alto Roundtable. So I have the privilege of introducing our physician speakers tonight, but before I do that, let me thank all of the physician attendees. Obviously, you've taken time out of work or home, and we appreciate you being here with us tonight, so thank you. Now, for the format tonight, we're going to do a roundtable. We've got a moderator with Dr. Mark Conrad, and then we have two panelists with Dr. Luis Gomez and Dr. Anthony Fagali. And the way that we'll run this is we'll have a small presentation at the beginning, and then really it'll be kind of a dynamic, free-flowing conversation between the physicians. Before we get to that, I want to kind of formally introduce the physicians for you. So Dr. Mark Conrad is with us from St. Elizabeth's Hospital in Boston, Mass., where he is both the chair of surgery and the chief of vascular and endovascular surgery. If you've heard of Dr. Conrad or haven't, he spent the majority of his illustrious career at the Mass General Health Network system, where he held both the chief of vascular and the endovascular surgery, as well as the program director of the vascular and endovascular residency and fellowship programs. Thank you, Dr. Conrad, for being here tonight. We have two physician panelists, Dr. Anthony Fagali from the SUNY Upstate Medical University in Syracuse, New York, where he is the assistant professor of surgery. Dr. Fagali attended medical school at George Washington University, did his residency at SUNY Upstate Medical University, and his fellowship at Thomas Jefferson University. Dr. Fagali, thank you for being here. And last but certainly not least, Dr. Gomez. He's a vascular surgeon at St. Joseph's Regional Medical Center in Mishawaka, Michigan. I hope I did that okay, Dr. Gomez. He attended medical school in Colombia, South America, before moving to the United States, where he did his integrated vascular residency at the Houston Methodist Hospital under the guidance of Dr. Alan Lumsden. Thank you for being with us, Dr. Gomez. I will now turn the call over to Dr. Conrad. I have two Endologics folks supporting tonight. Jeff Stodero from our marketing team is on the call, and Mike Simons, one of our regional sales managers, is also on the call. He will facilitate questions and discussion at the end of the call. Dr. Conrad, thank you for being here. The floor is yours.
All right. Thank you, Christina. And I'd like to thank everybody for attending tonight. I think this is going to be an interesting hour, and hopefully we'll be able to spark some good discussion. All right, let's go to the next slide. This you already have heard. This is my background, and then Jeff will go to my disclosures, and then let's get to the next one. All right, this is where we start. So I wanted to start by giving you my story and how my practice has progressed over 20 years. I started as a fellow at MGH, and there I was exposed to all of the major grafts that we were using. So it would be Cook, we used Medtronic, we used Gore, and then even we used some of the early iteration of the Endologics graft. We really tried to spread it around. They wanted us to have experience with everything. As I started my career at MGH as an attending, I was pretty much a Cook user. And part of that was because I was very comfortable with the graft, and I thought that it treated bigger necks. I did notice over time, I wasn't happy with the long body concept and thrombus that would form in the grafts, but didn't really feel like patients had a lot of problems. We had a rep change, and the rep stopped showing up at our cases, and we were doing some hard things. And I ended up switching from Cook to Medtronic. I really liked the idea that when Medtronic came out with the screws, and that you might be able to treat shorter necks as well. But then Dr. Schermerhorn's paper came out in New England Journal of Medicine, where we found that the early survival advantage of EVAR was lost over time over open repair, and it was really driven by failure of the mechanism. And I started to question whether getting a seal from an oversized graft that has external force against the aorta is really the right answer. And was interesting to me that no one else was looking at that. then I went to a talk with Michael Shobatov, from Trivascular, and he talked about how they reverse engineered the concept of coming up with a polymer to seal and separating the seal from fixation. And I really thought this was a very smart way to approach this. And as we were looking for alternatives, I thought this made a lot of sense. And I've got some slides that talk about how the actual seal works, because initially when I heard about the graft, I just assumed that the polymer exerted outward force against the aorta, just like all the other grafts did. It really doesn't. And I thought, well, maybe this might be an answer, if not the answer, to neck dilatation and some of the problems that we were having over time. I always believed that you needed to have a go-to graft, and then you needed to have a second graft that you can use for the difficult anatomies. The AFX was one that I used regularly for, and still do, for tight distal aortas, reverse tapers, that type of thing. But then once I got my hand on ovation, I really liked it for the tortuous necks and tortuous iliacs. I thought it delivered nicely, and then getting to Alto with shorter necks, it really made a difference. And so I would say my practice now at St. E's is probably 80% of my patients come from other vascular surgeons where the necks are too short, and usually they're asking me to do an open repair on somebody on home oxygen or something. So if I can't do an open repair on these patients, I find that the Alto is a really nice option, even in very short necks, and it's really become my go-to graft. So that's how I became an Alto user. So let's talk a little bit about the Alto stent system. Next one. So Alto is it actually treats a couple of things here. It allows you to treat patients with very short necks. It allows us to treat patients with tortuous iliacs, and it also allows us to treat tortuous necks. So I think it does become very versatile, and it not only is good for treating your normal anatomies, but it will help you to treat the more difficult anatomies. Next slide. So the key to the seal zone is this adaptive technology, and I think this slide really shows it well. So you pick a spot on the aorta where you're going to have a nice place for the polymer to come on and for the ring to form. But it's nice because even if you have some calcium there, the polymer will mold around the calcium and you'll still get a seal. Whereas with a traditional graft, that will also often lead to a gutter, and you don't have that gutter anymore. And so that's nice. When the ovation first came out, there wasn't a balloon there, and so we were always making a decision: do we balloon, do we not balloon? Alto has a balloon in place, and so you balloon everyone. And I actually think that gives a better result, because it does help to mold the graft along the the polymer ring to the aorta exactly the way you want it, and it's going to give you your best seal. And again, it does not actually exert any force once you have the seal. Next slide. And so this slide just shows that concept. So the first picture shows how blood pushes pressure against the aorta, and then the traditional graft in the middle, it shows that you still have transmitted pressure where you're having the oversized seal. And so that's why in larger aneurysms, when you're sealing with a 36 and a 32, that's still an aneurysmal neck, and you tend to have dilatation. Whereas with the Alto, you'll have your seal and no longer transmits the pressure against the neck. And so next. All right. Well, I have a case to talk about, and so we'll just go right into it. Next slide. So this is interesting. This is a 72-year-old gentleman with a 5-centimeter AAA, and you're going to say, oh, that's not righteous, we shouldn't fix this. But he was severely limited by lumbar disc disease, and was actually sent to me by his orthopedic surgeon because he was going to have back surgery, and they wanted me to fix the aneurysm first. What was interesting about this is when I looked at this thing, I said, oh, I don't know if there's an endo option for this, mainly because when you look at those iliacs, and I'll show some close-up view, the iliac bifurcation was essentially occluded. So he had aortoiliac disease, and I felt that the neck wasn't that great. And so regularly for a 72-year-old, I would have done him open. But when we talked about it, he didn't really want to delay his back surgery. And so we were trying to come up with something where I could do an endovascular option for him and he could get his back surgery more quickly because he was severely limited. All right, let's go to the next slide. But as we went through here, some of the pitfalls I was worried about was, when you saw on the last slide, was the aortic bifurcation was nearly occluded. In fact, he didn't really have femoral pulses. And so a couple of things that we thought about was needed to have the graft in kind of a perfect position for the seal, because you can see where the renals are and you can see that the aneurysm started. It's a pretty short neck. And then we were also concerned that the flow lumen was very small and that we might have difficulty selecting through there, although that ended up not being a problem. And then you can see the circle in the middle is that narrow distal aorta. And with that, I was concerned that with the delivery system in place, we may not be able to get the contralateral limb up. So what we ended up doing was getting the sheath through the bifurcation, both of them through at the same time, so that we almost deployed them simultaneously after we had the proximal area deployed. And so you can see as we go through these that the last one is the deployed graft, and it sealed very nicely, and we had good flow, and we ended up doing kissing balloons in the bifurcation, which I'm sure I cracked at that point, but it rolled out very nicely. Next slide. And going back to the case plan, these are some of the things we were worried about. You can see the calcified aorta in the first view there. And so we really wanted to make sure that we picked a perfect spot for the polymer to land. And I think that's one of the differences between Alto and some of the other grafts that you use. If you have a 1.5 centimeter neck, then it doesn't matter. You just drop the graft in and it's fine. You can see the max diameter there, and then that severely narrowed aortic bifurcation really was near occlusive. And I was actually surprised how easy we got through it. And then you can see the rotating, the final result. All right, next slide. So this is the interesting thing. So here's our 30-day follow-up, and a couple things to note here. The first thing is that miraculously his back pain and his claudication went away. So it turned out that this was all aortoiliac and not necessarily his back. He ended up not getting his back surgery. So hopefully I didn't lose a referral person. But either way, it was an excellent result for him. And then you can see that in that the last thing, the aortic bifurcation, where we ballooned it, both of those limbs stayed open very nicely, and so they were not crushed. So you have enough outward force there that even going through a very tight bifurcation, it sits nicely. You can see how calcified those iliacs are, and how calcified they were, and the 13 French delivery system really made a difference and made it easier to deliver. The other thing is the profile is so nice on this graft versus other ones that the sheaths go in very nicely, and I find that even in a very severely calcified aorta or iliac, I'm able to open it with a 5 balloon, and then I can usually get the sheath to go right through. So it's easy to deliver, and it helps you to treat really difficult anatomies. So next slide. All right, so that's my start. I'd like to get Dr. Fergali on here. Hopefully he'll.
Yeah, thank you everyone for taking the time this evening and not watching football to listen to us. My background's a little bit different. I have a bit of an engineering background. I'm very much interested in device development. I have a few patents. I'm working on filing another patent actually yesterday. So for me, I look at this as an engineering perspective of believing that polymer, you can do a lot more things than your traditional nitinol-based structured grafts. And I think I've had some very good success with it. A lot of the cases I've used this quite frequently in have been very challenging cases. So I keep my rep very busy, and the gray hair on his head stays. But I'm just going to show you some cases I've done. And this is one case, ironically, I did a couple of weeks ago, I just saw in the office today. So we can go to the next slide.
Anthony, before you start, can I ask you a couple of questions?
Sure, Mark.
I just want to get more of your perspective there. So what was your perception of Endologics before you started using their grafts?
So I trained in Philly, a busy aortic program. We were heavy cook. We did a lot of ZFIN, physician modified cases, Gore IBE. The only exposure to Endologics as a company as a whole was really aorto-occlusive iliac disease with AFX2. And even in that, it was very limited. So we did not use any sort of polymer technology, no Ovation, no Alto. So this wasn't something I adopted until later in my career.
So why did you start using Alto, and now how does it fit into your decision making and your practice today?
Yeah, that's a good question. I started to get a bit of exposure just reading some of the clinical cases, data, things that some of those LinkedIn conferences, talking to colleagues. And, I really believe that being able to provide access in cases in very difficult anatomy that we're really not able to do with any other graft was an amazing, tool to have in the box. I even had a case early in my career. I was a very busy cook guy, and there's nothing wrong with cook. I still use a lot of cook, but I couldn't even get the graft up. It was a very tortuous, calcified iliac in an elderly patient. So I had to abort the case, and then I ended up doing an Alto case or an Ovation at the time, and it worked wonderful. So it was a bit of, learning through experience and then understanding what you can do with that technology. Obviously, this is an all on-label discussion. I was just mentioning earlier, I had a rupture 2 weeks ago with a 1 millimeter neck, had success with it, preserved the kidneys, and patient did great. So, you have to kind of understand there's a lot of ability with this technology. It's, I really believe that with that polymer, you can do a lot more with it. You can create unique seals with the low profile. It's not even just that it's a 13 French delivery system. It's a very soft, trackable system that's very flexible, and it can take a lot of turns. And so you can have a lot more ability to treat these patients who are really not open candidates, and you can really get a lot of good success. And that's kind of been my transition.
Yeah, I think that's a great point. When you're doing whatever's necessary to get a seal in somebody who's not an open candidate, you want to have at least an expectation that you're going to have a durable result. And so, some of the other things that I've tried have never been happy with. Snorkels don't really work for me. And so being able to seal below the renal even in a short neck, I think is a great thing. Kind of speaking of snorkels, what's your thought about? I didn't mean to cut you off. Go ahead.
No, I was just going to say, I completely agree. I've had a lot of failure with guttural leaks with snorkels and chimneys. I even published a paper years ago in JVS on using aptus screws with IVUS to identify placement, and I was still having issues. So, I'm not a fan of personally drilling holes through graft and trying to catch the aortic wall. I have not had great success despite having had a paper out there about this. So, I've kind of learned over the years, and it's nice to have unique tools and unique engineering approaches to fix a problem with very good success.
So what do you think about this whole concept of failing up that we hear about at all the meetings?
Yeah, I think there's a lot. I think that's what drives us as vascular surgeons, and a lot of the reason a lot of us went into vascular surgery is we want to continue to evolve and provide improved outcomes, improved care. We learn from the mistakes, we try to improve upon our challenges, and I think the technology is evolving. Just 2 weeks ago, we did a detour bypass, which was phenomenal, in a patient who was not an open candidate, had no vein conduit, and went home the next day. So I think the technology is continuing to grow. I believe in challenging the technology, and I really like what I've seen with Alto and using the polymer to do so.
Excellent. Let's hear your case.
All right, we'll go to the next slide. So ironically, this was a patient of mine I just saw in clinic this morning. Next slide. So this was she's a 72-year-old female, actively smoking, not the greatest health. She uses 2 liters of oxygen at home. She had a very large 6+ centimeter inferior aneurysm, and it was a very challenging aneurysm. She had a very angulated neck. It was very short. It was about 9 millimeters, and her iliacs, obviously you can't tell here, were very tortuous. And not, large in caliber. She definitely was not an open candidate. And so she was a case that I was able to do with some sedation and local because of her severe COPD. Next slide. So, her neck was very short. It was about 9 millimeters. From the left renal, which is her lowest, I had about 19 millimeters. And then right below that, within a centimeter, it completely had this reverse taper that just blew up to 27. And then you can see on the far right, the severity of that tortuosity, which you couldn't appreciate on the 3-dimensional recons. And that was a very big challenge to be able to get anything up. So we'll go to the next slide. So this is just the DSA imaging. You can just start to appreciate where the renals were and how short of a neck that was, 9 millimeters. I was able to put my, my balloon markers or my arrow markers right at the level of the renal, so I can get that polymer to fit right where I wanted it to. And the nice thing is, what I personally like when I see very angulated necks, I like to get the grafts going and let the polymer fit. And then I pull my Lunderquist wire down because I want that polymer ring to really start to conform to the patient's anatomy. I don't want to create a stiff shaft and balloon that thing and then kind of create an artificial, luminal gain. I really want it to take to her normal anatomy. And that's the unique part with the polymer. You can actually start to shape it to how her anatomy is. And so that's the good part. And that's just the last image, is showing that balloon. And then my Lunderquist wire was pulled down. Next slide.
Hey, before you move on, Anthony, can we go back? How hard was it the first time that you deployed the graft and had to put the markers like in the middle of the renal arteries?
Yeah, that was a challenge. I think kind of going a couple years back, even with Ovation and now Alto, you're always on the fence. Am I getting a gel or renal? Am I going to cover renal? I won't lie to you, I'll be honest. Not in this particular graph, but in previous experience with other graphs, I have covered renals. So you're always in the back of your mind trying to engage it. But your RO markers are right at the top of that graph fabric, a bit above. So you're okay. You have a bit of coverage below that. And so you just want to get as close as you can to that renal, and that's going to give you the best seal opportunity. Yeah, and you can see that dot on that final image. That tells you exactly where that top balloon is.
Yep.
And as Dr. Conrad said, the polymer forms that ring, and then the graft is inside of it in a way. So you're still going to be able to get some flow into that renal. You're not going to include that renal. Next slide. And this is just a completion. I mean, this was a very difficult neck, very angulated, large aneurysm in a woman with horrible health issues otherwise. And I saw her in the office today, and she's done amazing. I already have a postoperative CTA. And it looks beautiful. She's got a great seal. There's no evidence of any endo leak. She's recovered phenomenally well. So it's great to have access to these technologies that you can seal things that are very challenging. Normally, you have to try to fit a graft or put an aptus screw.
Hey, lay down. You're not going to get it.
And so there's just a lot of unique abilities with this technology, and that's just a bit my experience with it.
And you can see where your ring is. It's really close to that left renal, and yet you've got good flow through there, and it's going to be nice. What did you have to do with the iliacs to get up the tortuous iliac?
I had to do nothing. Personally, I just try to get a GWA or Glauber Advantage up or some sort of wire and convert it. And generally, I can track up a GWA. If it's really difficult, I'll change it out for a stiffer wire like a Lunderquist, and I can usually track up it. I do other things. I do, the lithotripsy systems. I balloon, I crack and pave. But in my personal experience, I have never really had the difficulty ever with an Alto or previous innovation with it. So I've been very fortunate in that. I've had other grafts, I just can't get them in. Trying to get a 22 or 28 French sheathing can be very challenging in some of these cases.
Yeah, it's a great case. All right, next slide. Is that? All right, thank you, Anthony.
Sure.
Get Lewis up here, Dr. Gomez.
Right here.
All right. I'm not seeing you, but okay. Welcome. Why don't you tell us a little bit about your journey here?
Well, thank you everybody for joining us tonight. As Anthony said, there's perhaps more interesting things to be doing on a Thursday night than watching a conference, but thank you for being here. So my, again, journey a little bit different than most people. I grew up in South America, went to med school here, moved here and was fortunate enough to enter the integrated vascular program at Houston Methodist Hospital, which was DeBakey's original vascular fellowship program. I trained under Alan Lumsden, who does a ton of complex aortic stuff. We mostly used GORD products. So my experience with endologics was zero during training. I joined the St. Joseph's Regional Medical Center after graduating. And by the way, Christine, you did perfectly fine with the pronunciation of the city. We're about 5 minutes away from Notre Dame, so good football town.
So what was your perception of endologics before you started using their grafts?
So as I said, we mostly use Gore. We used other devices, but that was our go-to company. And when I came here, my practice is just me and one partner. He had one case during the first couple of months that I was here with Endologics, and I met with the rep. We kind of sat down and went through the technology. He showed me how it worked, and that's how things kind of like got started.
Did you, when you started using it, did you jump right in, or was it sort of, did you use it for difficult anatomies first?
It was just difficult anatomy, and the case that we're going to present had to do with that. It was my very first case. It had a short angulated neck. The patient was not a good candidate for open repair, and I had the conversation with David, our rep, about 2 weeks before that. So I called him up. He looked at the images, and we figured that it would work, and it actually worked out great.
And how does it fit in your practice now? Are you a believer to use Alto all the time, or is it still?
I would say I'm close to 80% Alto, and then some of the other devices a little bit less. But yeah, I truly believe in it. I mean, the fact that the sealing rings are there and you don't have a stent through that part lets it contour. And you do mention a couple of things, and Anthony did as well. Removing the wires, the stiff wires, so that you can allow the graft to kind of like contour to the anatomy of the patient, that makes a huge difference towards the end. And when you have tight bifurcations, you're able to basically crack them, and because you have good seal above and below, it prevents them from kinking down and keeps the patency of the graft.
Yeah, I think you're right. Every graft has its nuances, and that's one of the most important, is that when you have an angulated neck, you definitely have to pull that stiff wire back, because you really want the polymer ring to conform to the aorta and not some strange version of it with the stiff wire in place, as it accordions down. Why don't you tell us about your case?
All right, let's go to the next slide, Jeff. Next. So this was as I said, the poor surgical candidate, 66-year-old male. He had a 8-centimeter AAA who presented to the office. And if you see on the far right, you actually see the angulations of the neck. I believe the top part was a little over 70 degrees and then 120 degree coming the other way. Looking at that anatomy, trying to get one of the other modular devices would have been challenging, to say the least. So that's when I talked to our rep and we went through it. Even the software that Endologics uses to try to set up the 3D model was having a difficult time trying to adjust the grafting to the patient's anatomy. But based on the available data and the measurements that we got, we decided that he would be a good candidate. So we proceeded with that. Next. So here you see the pre-case planning. So 71.4 angulation right below the neck, and then the 120 degree angulation of the aorta. I believe the maximum diameter we got an average of 18 or 19 millimeters for the neck. We opted for this configuration of the Endologics device and went with it. Next. So in here, the pre-graft angiogram, you see, even though it's still tortuous, there's a significant decrease in the angulation once you have the stiff wire there. And just as you guys mentioned, trying to get the arrow markers right at the level of the renal or right above it, it's stressful at first. Again, this was my first case, so you don't really know how the device is going to work. But once you position it properly and you deploy it properly, it hasn't happened to me yet, where you cover the renals with this device. The other thing that's very important is the integrated balloon, which kind of like saves you time. You don't have to pull things out and get them back in to try to balloon and seal everything in. And that it's kind of like an extra perk. That's the way I see it. When you have the device and you just balloon it, you don't have to take things out and put them back in. It works great. And on the far right, you can see the final angiogram. We had a perfect landing with the sealing ring, and there was no endo leak of any kind at that time. Next.
Wait, before you go, when you have let's go back. When you have a really angulated neck like this, what kind of things did you have to think about when you're deploying the graft, especially the spatial relationship of the contralateral limb? Is that something you guys worried about or talked about?
So we talked about before it, and we just wanted to make sure that above we were properly landed, and then we were going to worry about that down the road. And you have the possibility to go up and over in an antegrade fashion if you have the problem of cannulating retrograde. So we were not as worried about that, but it's something that you have to keep in the back of your mind when you do that.
Yeah, one of the things that we really pay attention to now, especially in something as angulated as this, is that you want the ipsilateral limb to be sitting on the angle and the contralateral to be shooting out on the other side, or you want to go anterior posterior, because if the contralateral limb opens on the angle, the actual delivery system will occlude it. And I actually had a case like this where I didn't even think about it, and I ended up eventually having to go through the arm because I tried to select it and couldn't get through, and then we went up and over with the wire, but I still couldn't get a catheter to go through the occlusion from below, and I lost my wire access. So we ended up having to cut down, come from the arm, and get through there, and said, boy, that's something we got to think about, because there really isn't a lot of body between the rings before you put your next stents in there. And so I just think when we're talking about doing these difficult necks, it's something that the planning with Alto makes all the difference, right? This isn't a graft that like some of the other ones where you can say, oh, it's a long neck and going to be easy to seal, or we'll just throw something in. You really have to be deliberate about the way that you set things up and the way you plan.
Correct.
All right, next one, go on.
So here we have the 30-day follow-up where you see the ring here on the top left part of the first picture. You see that the ring basically contoured to the anatomy. You don't see any leaks around it. There are no kinks throughout the graft, and good seal zones proximally and distally, and the patient has done great. So it was a great result. It was a very complicated anatomy for some of the other endografts available, and we had excellent results with the Alto device. Next. I think that's it.
Yeah, that's a great case. It's interesting. I had a similar aneurysm like that early on in my career. We called the turkey because it was around Thanksgiving. It actually looked like a turkey. And what was interesting about that is she was wheelchair bound and very sick, but she had 9-centimeter aneurysm. I fixed her thinking this didn't have to last very long. And I think she was 90 at the time, and she lived to be 98. And the aneurysm actually got better for whatever reason. She got better and was no longer wheelchair bound, and it was like a new lease on life. I have no idea why that aneurysm made her sick, but it's just interesting. So sometimes when we treat the patients, it makes a huge difference for them. Those are great cases.
Yeah, that's a great case. I mean, getting a seal and be able to track through all those turns. I mean, those are challenges, especially your first case. So I mean, that's beautiful. As Dr. Conrad mentioned, I always watch, those really long necks, because you want to make sure that you have enough space that polymer and the gate, the fluid diverter is going to fully expand and open up. Because if it's taking those angles and it's taking a lot of very narrow neck, you don't always have that full apposition. So always something to be cognizant of. But I don't see any other graft that's going to be able to take all those turns and deal with that and really get a great result.
And if you are tortuous there and it's not opening up very well, I have extended with covered stents higher to give it some more body, and I had to do that once as well. But this is one of those things, we are asking this graft to do very difficult anatomy, and so you just have to, in every case, you learn a little bit more about the tips and tricks to make things work. And I think that's so important when you're asking a graft to do things that no other graft can do. You gotta kind of think on your feet.
Yeah, and I've reinforced them. I've put VBXs, just obviously we're not going off to other industry, but just to really give that radial force to allow that flow diversion to have good support. And so there's a lot of unique things. I've also done it where you can come in and put chimneys. If you don't have a great renal, it's not a Zephyr candidate or physician modified candidate, and you can allow that polymer to conform to your renal stent. So there's a lot of unique things that this technology has. Obviously tonight we're focusing on IFU, but I think it's very good to start to develop ideas, because the vascular surgeons are always trying to grow and develop and push things. And I think this is very exciting technology to have.
Correct.
Yeah, go ahead, Liz.
Oh, sorry. No, what I was going to say is one thing that we haven't mentioned that I think it's interesting, and I've done it when I've done my Alto cases, is that you can finish these cases with 11 French sheath and a 9 French sheath. So like, for example, if you have an 11 French pinnacle sheath, and please guys stop me if I'm not supposed to be saying any of this, but you can match the outer diameter of the main body delivery system, which is a 15 French. So you use an 11 French sheath. It just allows for a little bit of versatility. Or like, for example, the outer diameter of the 10, 12, and 14 French or the limbs will match 12 French sheath. And it's also another thing that you can do, just get rid of the delivery system. You can get the sheath in and finish the case with that.
Excellent. What I was going to say also is, if you're going to start using this graph, put it in a couple easy anatomies so you get used to it, and then start doing the tough cases.
I was
Christina,
thrown through the fire, but fortunately it worked out well.
Yeah.
Jeff, are you going to ask questions? There's a lot of questions coming in from the chat. Do you want to?
There are. So first, I'd like to thank all three physicians, Dr. Gomez, Dr. Pagali, and of course, Dr. Conrad. We got up to 84 participants on this call. So that might be a new record for us. So thank you. We do have a lot of questions coming in from the chat. First question, what are the thoughts on the lollipop technique to palm off?
I can answer that. You know, it comes in waves for whatever reason. I've had 2 or 3 of these in the last 6 months. You know, I've had cases where it's very large diameter necks. You're really kind of pushing the IV boundary of your maximal polymer diameter you can get. And so I've had, you know, as I mentioned earlier too about the 1As, with a Palma's stent, you're able to get about 3 to 4 millimeters of stretch on that graph to really get rid of those 1A endoleaks. And that's been my personal experience. And I don't know about the other two.
Yeah, for me, a couple things about palmar stents. I think actually the reason that it works so well is because it does now push that fabric that's standing straight up and pushes it against the polymer and gives you a little bit more of a fabric seal. You know, for me, the most important part of using a palmar stent is making sure that the sheath it goes through is up to the level of the renals. Because if you can't get the sheath up there, that's when you have the problem. You can't bear back a palmar stent because you're putting it on a Z-Med balloon or some whatever you're comfortable with, but it has to go through the sheath to get up there. And we did a lot of palmar stents in residency or in fellowship. Not sure why. I think the grafts were just not as solid as they are now. But I've probably had to do maybe 5 palmar stents on the Altos, and they resolve the type 1 endoleak every time.
And these are endoleaks that I'm seeing on the table, 1As. I mean, these, you know, I've never had the situation, and I've probably put in well over 60 plus of these, and never seen a situation where I have a 1A down the road. It's always been that 1A on the table. It's very rare. And those are usually cases that are really close to off-label use, which are really short necks, very angulated, maybe calcified. And so by getting that palmaz and really allowing that stretch of the fabric, it's treated them all for me.
Yeah,
I haven't had to do it, but yeah, I agree with what Mark is saying. You, as long as you can get the sheath up to the level of the renals, you should be able to put it in a safe manner, and it does help with the radial force that it has. It's a great thing to add to your toolbox if you have the opportunity.
Yeah, and I think I learned from every type 1 endoleak, because I generally, when I think back, it's usually my fault, not the grafts. And so it does reiterate the most important thing, which is make a plan and stick to your plan. And you really do trust what you saw on the CAT scan, and don't really try to adjust based on what you're seeing, you know, on the angio.
And your fixation cage above the polymer is very large holes. So if, you know, playing devil's advocate, if you ever need to come back and throw in a physician modified segment or a Z-fin or chimney above, you can easily get back into those renals and do it. You're not burning that bridge.
Yeah.
Yeah, exactly.
Okay. So thank you. We have a couple more questions on the line. You also have the opportunity to come off mute. Dr. Gomez, we'll start with you. They appreciated the cases. Dr. Santana, just curious if you've ever had to explant the Alto graft.
I've never had to.
Dr. Pagali?
I have not. I have explanted other graphs, but no, I have not in Alto. No.
I have.
Okay.
Of course I have. It's actually pretty easy. What we did was I did leave the cage behind and basically just cut right at the level of the polymer, just right above it, and then just sewed to aorta and that little bit of fabric that was left. And it was just fine.
And why did you have to explant, Mark?
So it was a patient with a type 2 endoleak, and the aneurysm was now 9 centimeters, and they had about 4 interventions, and it wasn't working. And basically, there were 2 sacrals that we just couldn't get to get rid of. And I didn't do any of the other treatments, but the patient came to me for an open repair.
And so by cutting it out, you're able to visualize those type 2s and internally ligate them and then put a graft?
Yeah, so what I do in that situation is I will open the aorta without putting without putting any clamps on, because I want to know. I'm always interested, why are we here? And they were just really robust sacrals. So before we did anything, we went in and just oversewed them, and then ended up. I was going to try to do the, when you explant cooks, there's that technique where you can take a syringe and cut it off. And I thought I might be able to get away with that, but the polymer wasn't going to go through the syringe. So it didn't really work. And I think I probably could have gotten it out, but I didn't do a superceliac clamp. I actually clamped just above the renals. And what's interesting about that is that cage actually collapses very nicely and opens right back up. And in the follow-up CAT scan, it didn't destroy the aorta or cause any problems. So soft jaw clamp on there, and I was able to clamp the suprarenal fixation, then just cut it out and sew.
Okay. Thank you. Another question, Dr. Fagali, if you don't mind, we'll start with you. We know that there's a couple options when you're going to cannulate the gate, retrograde versus crossover lumen cannulation. Do you have a preference on this, and any tips and tricks?
I do. I guess they're failing forward again. We're stubborn as vascular surgeons. We think we can cannulate anything, and we're going to spend, 10 different Vanchi sizes to try to do so. Personally, if it looks very angulated, it looks challenging, and I'm messing around, I have my fellows or residents, and it's been a few minutes, I'm not going to waste time. It's so easy just to snare that wire and just chase it back up. I personally, I'm more, speed kind of guy, so I'd rather just be able to move forward and do what I need to do. And I'll be honest, it's a tougher gate to cannulate than some of the other grafts, because the way the polymer rings are, there's not as many markers. They're kind of feathered together a bit harder. So by having that pre-cannulated option makes it much, much easier. I know we don't always talk about our failures, but I once had a case where a 90-year-old rupture, and I had a fellow thought she cannulated the gate. The polymer wasn't filled yet. She thought she spun a pigtail, and long story short, the limb was behind it. And so at that point, I'm talking coiling and plaster plugging across fib. So if I'm going to suffer and it's going to be a challenge, I don't waste time. I just go to snaring that wire.
I agree with Anthony. I mean, we'll always give it a try, retrograde at least once, twice, maybe 5 minutes, but you have the option to go antegrade. It's, less floral, less radiation for the patient, less radiation for you. Just go ahead and do antegrade, snare it, and get the case done.
So that's the fun for me. I put the fellows on the clock and watch them sweat, and they get 5 minutes. And if they can't, usually I figured out what they're doing wrong, and then I can select it right away and be like, I can't believe you couldn't get that. And so that's always a fun way to do it. But if we can't, we'll definitely use the snare over. It's funny. I am terrified of creating endotrash like you just talked about. So even when I'm certain I'm in, I still put a 10 or a 12 millimeter balloon up there and take 2 pictures just so that I'm always 100% sure. Because there's nothing worse, right, than realizing you just put the limb in the wrong place. And then it's like, wow, this was going to be an easy case, and now I'm going to miss lunch. Right.
Yeah. So, this was like a midnight case. I was
all right. So now you're like, oh,
that's happen at noon. That happens the last case of the day where you think it's going to go well, and then you spend all night trying.
But I mean, there's no golden leaf. I mean, you have to be honest. I mean, there's challenges to anything, and I think having something you can pre-cannulate and pre-snare it just saves you a lot of misery. And the other thing too, I think, as Mark mentioned, it's nice to balloon it and see the separation and make sure the balloons are in, we're talking like 12 mm balloons. The other thing too is your polymer has to set. And so one nice thing is this system has a balloon built in. So if you're not there yet, you can go ahead and balloon that polymer and get it to form. And so you're not burning through, wasting time trying to worry about that.
So interesting segue, Dr. Fagali. So we'll just kick this back to you. Is there ever a time where you don't balloon or a situation? And when you do balloon, how long do you leave that up for the polymer to cure?
I think Mark mentioned this well earlier. I think the balloon is great. It gets you full wall apposition and it allows that polymer to completely conform to plaque, to disease, to really fit to the patient's native anatomy. There's no other graft out there that can do that. No graft. I mean, every graft is just a fabric with a nitinol ring. This is a polymer that will conform to anatomy. So by having that balloon, you can really get an amazing, adaptation to the patient. And you can keep the balloon up. You can keep it up. It depends on how tight that anatomy is. In general, you can keep it up for about a minute or so. So it really depends what you're looking to achieve.
Okay. Dr. Gomez, anything else on that?
I balloon everybody.
Oh, Dr. Conrad?
Yeah, there's no reason not to. You might as well. This is your one time to make it conform. You can't come back and balloon it a year later. So I balloon them all. If I'm worried about it, I'll leave it up a little bit longer, but usually I do like you would balloon a normal graft. So, just take it to profile and really see that it's sitting nicely.
Correct. I agree with that. And just, sorry, one thing before we continue to move on. One of the things that I've found helpful whenever I'm cannulating, whether I'm going up and over or retrograde, it's the Nitrix 014 wire. It doesn't kink as much, and it helps. It works great.
Yeah, I think that's a good point because I have used 014 glide wire advantages, and if you snare the stiff shaft and not the flexible tip, that can bend. It can get very difficult to get it out. So I think a Nitrix is a nice wire.
Yeah, I like that.
So Dr. Gomez, one of the things that our sales force talks a lot about and a nice place for Alto is angled necks. So can you talk a little bit about your experience when you use self-expanding grafts, why that Alto may have an advantage in this subset of patients?
So as I mentioned, one of the things that I like about the device is that it doesn't really have a stent in that segment. So you can really mold it to whichever angulation you have, and you know that it's going to conform. Once you fill the ring with the polymer, it's going to conform to the anatomy, and you're going to have a good seal without having the risk of the device, not deploying properly, or having a type 1A endoleak at the end just because the angulation of the neck wasn't properly adjusted for. So that's one of the advantages of the device. Is one of the things that I've encountered and that I like about it.
Okay.
The stiff grafts with the stiff suprarenal fixation, if you're really angulated, it will cause a little bird beak that becomes a gutter, and you can't get rid of it. And that's a real problem. And then the other thing is, if you're short and angulated, sometimes when you deploy them, it just kind of watermelon seeds down, and you're like, what? Why is it so low? And so, the nice thing about the Alto is you pick your position, you drop your suprarenal fixation, you're not moving. And so at least at that point, that you are in the position you want to be.
And with a normal graft, if you oversize that, it starts to accordion, and then now you're trying to put in apta screws or some sort of anchoring system, and you're just making those gutters worse. And this is nice that you can avoid all that.
Correct.
So last question on the chat, Dr. Conrad, you've obviously done a lot of follow-ups when you've done your Alto cases. Have you ever focused on neck dilatation in your longer follow-ups?
So I haven't, but the data is out there from Ovation and from Alto. That was the combined data, and there's a slide that I have out there where they looked at large necks, so anything that was in the 30s, and their 5-year neck dilatation was incredibly small. It was, I don't want to lie, it was like 1 or 2%, but it was very low. It was to the point where I was like, wow, that's amazing how low. It might have been less than that. So it really does make a difference. You don't have that outward force that you have from the other grafts, and I think that does make a difference. You know, we were always taught with open surgery that you have to sew to normal tissue, you know, and when you open an aorta, you can see the ring where the aorta is normal again, and that's what you sew to. But we do EVARs in 32 necks, and those are aneurysms, and so I do think that those are the ones that are very vulnerable to growing with that external or with the continued force against it, and we just haven't seen that with Ovation or with Alto.
Correct. I agree with what Dr. Conrad's saying. You know, even with open repair, you can have neck degeneration depending on what the aorta looks like or it's like after the repair. But having the rings there, I think, absorb the pressure. That's what the ENCORE data showed. It just absorbs that pressure, doesn't really transfer that into the neck, and that decreases the chances of neck degeneration.
So again, thank you to all three physicians. I can say without a doubt that this is one of our strongest calls that we've had. Thanks to the 84 guests that we've had tonight. I found it very informative, so I appreciate it. And hopefully we will speak again soon. Thank you.